So very good afternoon, and thank you for having me. So the case that I'll be presenting is called shooting in the dark. So this was somebody who's undergone LASIK surgery in the past. This is a 35-year-old lady, and the challenge now is the IOL power calculation. So she has a cataract now, and we have to plan surgery for her. Now, when the optical biometer here refused to give any measurements, from the axial length that you get from the ultrasound, you can see this is a high myope. And what is really surprising here is just see how flat the cornea is. So you see keratometry K-mean values of about 25, 26. When you look at the EKR map again, you can see in some of the zones values as low as 21, 22 diopters of keratometry. Now, I went ahead with trying to calculate the IOL power with the ACRS online calculator because that's what I usually use. But the calculator refuses to accept these values and it goes and tells you to check the values instead. So the lowest values, which I realized on this occasion that the ACRS calculator accepts, is 31 diopters. And this is the IOL power that you get with that. So there is really no direct way to get the IOL power here. So all I did though was, which I could do was do a bit of a trial and error, see how the IOL power is changing as you move from 31 to 32 to 33, and then try and extrapolate it. And it is a lot of guesswork. It could have been wrong. And so I went ahead with the IOL power of about 21 diopters in this case. We did have some residual hyperopia, so we fell a little short. The other eye, I chose to go with 23 diopters because I wanted to get closer to the target. We had slightly less residual error here and almost hit the target. The patient was happy because we had counseled the patient quite well, but really this could have gone anyway and I could have been wrong as well. So, which is why I would like to ask the panelists, what would you do and is there a better way to manage this?
Can you go back to the first slide where, why did you not manage to get any readings on the optical? I mean, other than, what did you manage to get on the optical?
It didn't really give much because I think it is because of how flat the cornea is.
So if it's flatter than 30, sometimes the keratometry won't come at all.
Yeah.
And if it's, but the axial length you managed to get, right? Or that also was
the axial length also the optical biometer was not getting, so we had to get it on the ultrasound.
Okay, so quite a tough thing. So I think we have a full panel and we'll ask our panelists if anybody would like to suggest. So you eventually use the ACRS calculator with, what all did you put on it? I was actually, caught with Dr. Kudlu telling me something.
Yeah.
Because we do use the EKR 65 values and they work well on that. Was it not accepting it?
Yeah. So as you can see, I use the Pentacam EKR map values onto the ACRS calculator. The AC depth is something that I had. None of the other measurements were there. And so this is obviously not something that I got. Then
so
I just entered.
See the Pentacam input, not here, on the ACRS?
So on the ACRS, I had to basically enter 31 diopters. And this is what I got. So, and then I saw how these values were changing as I went higher above 31. Because if you go below 31, the calculator doesn't give you anything. So, and then I just had to extrapolate it and assume that it might, with a reduction in the K values, this is what I would get, and that's how I went for it. But it was definitely not an exact measurement. It was more of an assumption, and it was a risk. So the other option was to leave the patient aphakic and do a secondary, do an IOL later on.
I mean, it's all fantastic what you have done, but I just wanted to know, did you use only one instrument to measure it, or did you try to do it?
We used to. So we have one lens star at one of the centers. We didn't get a measurement with that. Neither did we with the IOL Master.
Okay,
the IOL
so
Master we have is the slightly older one.
Despite two, you got no,
No.
that means whatever readings you were getting are absolutely right. Then I think we'll just follow what you have done.
So Tushar, I've been in this situation before, and if somebody else has a good answer here. Yes, Rajiv. But what K readings will you feed? Because if it's flatter than 30, and you're not getting a measurement at all, so. Pentacam, yes. In fact, that's exactly true. Okay. And you wanted to test. And then you would use the Shamas? Okay. Sure. It works well, yes.
Okay.
Yeah.
But does the Shama's formula accept the K readings below 30?
No, that's the
so that also would not accept
that's
it.
the challenge.
Because
I have
think
a question. Would you like just go ahead and put a lens there and then do a piggyback for a residual? Or
You
no?
could, but then you don't want to do a piggyback, right? I mean, that should be your last option.
One option
Just-
is to use the Hoffer-Savini spreadsheet. So there are multiple key readings which you can input on that and multiple formula. So at least you will know what are the outliers and how close. So various formulas, Sharma's is just one of them. There are other Barrett's included. So you could enter all your data, whatever key reading you've got on your autorefractometer and your Excel link by the ultrasound. And then go in with different formulas. So you'll know what are the outliers and what are the closest readings. So that way probably you could have tried that.
But then if any of the formulas were taking these values, wouldn't the ACRS also have
So
calculated
Tushar,
it by
I'm
some
still
formula?
intrigued because your sheet does not show pentacam inputs. You're putting it in the topography inputs where it will not take it, okay? Can you see your maps? I mean, you don't have the pentacam inputs available anyway.
So-
and frankly, I have done
Yeah.
post RKIs where the case can be from pentacam, can be like 23, 24. And we have managed to go through the ACRS calculator using the OCT and the pentacam inputs, and we've got measurements.
So
and we've
where
got
do, what
results.
values do you feed, sir?
So,
then?
so there is a space for putting pentacam values. I'm
Yeah,
wondering
the
why it's not
apex
showing
4
up.
mm zone. So the routine way that I have calculated and which has worked very well for me, and it's something that we use during fellowship as well, is to use these ring values, and that corresponds quite well with the pentacam EKR map. But yes, I think what you are doing is probably the way to go in this case, because I haven't done that.
See, the pentacam thing seems vacant on the
Yeah.
on the extreme right.
Yeah.
So that will take what you get from the EKR 65 and will give you an output for the pentacam as well. And if you
Okay.
use the Avanti OCT and you can put in those OCT at the bottom, OCT RT view, that also helps. So we managed to
Okay.
get from those two things for me. I mean,
Okay.
if you have available those two things.
Okay, I'll try that
So,
out.
but pentacam definitely for us has worked the best so far.
Yeah.
Yes. Sorry? Yes, you can. I mean, in the past, that's what used to hold up
Yeah.
hold the best. Yes.
I had a similar case, but I had a case in which there was a post-RK, post-LASIK. So, in fact, the LASIK was done twice. So, he was blessed.
I had a similar one. Yeah, 22 or 23
I was
case.
getting an
Yeah.
IL power which was between 23 to 26. I was getting from different. So, I did the intraoperative. So, I finished
yes, sir.
and as a first case, I did other cases.
Yeah.
I didn't sit outside. Then I went outside and did the autoref, and then bang on it came. But what you have to do is I multiplied it by 1.9, whatever refraction
Okay.
you are going to get, because there is again there are different papers which say some papers say 1.6, some papers say 2. So I multiplied it with
1.9.
1.9 and I got it.
That worked well.
So
I think
have
that's
four such
very
ISOs
useful.
now.
Okay. And there have been cases where I find a discrepancy between the pentacam EKR map and the optical biometer, and I've usually found the pentacam EKR map has given me
but
very
only
good
for
results.
such eyes. If you tend to use it for
No, you can't use it
virgin eyes,
for
then
it.
you'll go
True,
horribly wrong
true,
as well.
true,
So that's a catch. So thanks a lot,
Thank you,
Tushar.
sir.
I